great idea to, we thought it'd be a great idea to bring in something unusual to expand the field of clinical reasoning. So we'll bring in cases that have a angle with POCUS. So that way we'll augment the clinical reasoning process with POCUS and see how POCUS can move the needle in the process of clinical reasoning. So stay tuned. We'll send out announcements. We'll jumpstart Tuesday with Debora and Madellena discussing a case that I'll be presenting. It'll be 1 p.m. EST this coming Tuesday. Mic to you, Robbie.
Amazing. That's so exciting. I think it's long overdue to talk and bring POCUS to VMR. I'm so excited. It sounds like an amazing group of people, and I'm really excited to hear Debora discuss the case. Rafa, tell us about what you wanted to chat about.
Hi, everyone. So I was talking with everyone here that we are doing the IMG special project again this year. And one of the projects that we're currently working on is the personal statement workshop. As an IMG myself, I know there are a lot of resources out there that people usually have to spend a lot of money, and it's so expensive. So we're currently doing this workshop in order for everyone out there who doesn't have the opportunity to be able to have their personal statement revealed. So if you want to submit and try to, oops, I'm so sorry. Let me send the link for everyone. This is the link that you can actually try to submit to be able to have your personal statements revealed. There's a disclaimer that it's only for non-US IMGs, and also only if you are applying to this match season, because probably they're going to do that again next year. And also, unfortunately, there's a limited spot, so we don't know if we can accommodate everyone, but we'll do our best. So thank you, Robbie.
Thank you, guys. The personal statement workshop, I think, is the first time that it's being offered so deliberately and publicly, and it's crucial. It really is. I think it'd be very, very helpful to come there and learn from people who've done it before and looked at many before. So I'm really excited that you're doing this, Rafa. These guys don't stop doing more and more incredibly creative things. Like, I don't think they can help it. And today is actually a little bit of that. This is an idea that we thought we would do to just add a different dimension to our clinical reasoning practice and how we do things. And yeah, we're excited to show you what we have in store. We're just going to review the 5 cases of VMR with kind of like a conversation style between the CP Solvers folks. If you have questions, please put them in the chat. We'll try to get to them, and we'll try to make the most of reflecting on these 5 cases. Shema, do you want to kick us off with Monday?
Sure. So on Monday, I had the honor to present one case. It was a vasculitis case, and this was a little bit tricky, I have to say. So I can say at first, if I didn't present it, I would have never solved it, because the tricky thing was there. The chief complaint was intermittent claudication of one leg. So the basic thing was we had only one leg that was involved. There was asymmetrical involvement, and then the tricky part was trying to evaluate what kind of vessels are actually affected. Like, when we think of all the vasculitis cases that we know, we always try to put them into the category as a small vessel or a middle vessel or big vessel. And then there was this problem how to put this into one category. But I have to say, this was very inspiring for me to see that you can actually solve this vasculitis case if you collect all the clues. Like what I learned from reading the case report, like if you don't have any pulmonary involvement, if you don't have any involvement of the venous system, if you don't have any involvement of the glomerulus capillaries, like glomerulonephritis is something that I would always expect in the small vessel vasculitides. And so we didn't have it here. This could have been a clue, but I have to say, like, I would have never expected something like this kind of peripheral arterial involvement in a case like PAN. Yeah.
No, that was an incredible summary. I agree with you. And I think the discussion was absolutely incredible. And you could see that this is somebody who knew exactly what they were doing. And yeah, I think you hit on the highlights, which is, it's very unusual to have one, in terms of claudication, it's very unusual to have just one leg be so painful. The most common cause of claudication is bilateral atherosclerotic peripheral arterial disease. So whenever there's marked asymmetry in the pain, that tells you that there's something unusual going on for sure. And we use that analogy with neurological diseases all the time. Whenever something is unilateral, it's unusual, and it's not. Peripheral neuropathy would be unusual for it to be unilateral. It might be mononeuritis multiplex. It might be something in the brain. And I think the theme in that case is when you hear claudication, your mind is going to ischemia. And I think the nature of ischemia is actually pretty interesting to reflect on. How quickly it evolves tells you a clue about the mechanism. So if somebody abruptly develops acute ischemia in the space of seconds or minutes, it's either some problem with the blood, a hypercoagulable condition, or it's a dissection. Like those are the two things that happen fairly acutely. And what this case is a reminder of is you can have the other extreme of it is atherosclerosis, super, super slow. It's like the dementia of the blood vessels, right? Like there's no real way to stop it. It's age related. And then there's something in the middle. And in the middle is often inflammatory diseases like vasculitis. So this person had been having claudication, not forever, but also not instantaneously and abruptly. Like if they developed it with no warning signs whatsoever, it's cardioembolic disease is really important to think about. So do they have AFib? It would be probably the most likely culprit, honestly. But that person was having this like middle ground claudication, which is a really powerful clue, I think, to vasculitis. And then it became an exercise of like, whoa, what kind of vasculitis? And I think, Shima, you hit the nail on the head. When you think vasculitis, you think immediately large, medium, or small. And what you should do then is to say, well, what does this case have? And there's no small vessel vasculitis at all in this case. There's no purpura, which is really important, and then no glomerulonephritis. And for it to be a large vessel vasculitis, presenting as PAD, it's possible. Giant cell arteritis, Takayasu's arteritis can do it. But the real clue there was the marked hypertension. So that was a clue that the kidneys were involved. And as soon as you say kidney vasculitis, kidney involvement, and claudication, it becomes hard to think of. I think that's when it focuses the limelight on temporal arteritis. Did any questions come up for you, Shema, or like any parts that you thought were hard to understand or digest, or really to anybody?
So basically, we were also talking about livido reticularis. It was also one of the chief complaints. I got a very great overview by Kirtan, and I would just ask myself, like, when we try to put the vessels of the skin into one category, can we say whether this is like small vessel, or how would you put it into one category?
Yeah, no, you're absolutely right. By the way, we should the one and only Dr. Jack Penner is here. I see that he has his video off and his mic muted, so he might not be able to talk, but it's exciting and awesome to have you here, JP. I think that there's a lot of truth to that. Does anybody want to shed light on it? The question of what are the vasculitic manifestations in terms of dermatology, right? And what does that tell you about the size of the vessel involvement? Anyone want to weigh in? Yeah, it's tricky. I think, are there any good general rules of thumb? I think the answer is yes. Whenever there's palpable purpura, small vessels are involved for sure. And the other manifestations actually can be pretty varied. So you can get ulcerations, as Ravi just said, and you can get nodule formation, and you can get livido reticularis. And I think for ulcerations, it's probably still 50-50. So you can get ulcerations from GPA, as Ravi just mentioned, but it's probably a little bit more likely to get it from a medium vessel vasculitis like PAN. So as a good general rule of thumb, if it's purpura, it's probably small vessel. And if it's all the other ones, livido, ulcer formation, and sometimes even paniculitis. So the deeper it is, the more likely it's medium, but there's a lot of overlap there. Yeah. Yeah, 100%. Rafa's emphasizing, usually think that PN spares everything but the lungs. It's a really good rule, just like syphilis. Yeah. Awesome. Other thoughts or questions before we jump into the next case?
So at the moment, I don't have any question, but thank you very much for this great rule. Especially, I like the one with the deeper the lesion, the bigger the vessel. That's really cool.
Yeah, you know, it tracks with anatomy. It's really interesting how it does that.
Yeah, I just want to add, there was a case, remember, Robbie? I think you solved ulcerations that seem like pyoderma gangrenosum. I think that came up in the differential, and it was actually a case of GPA.
Yep. Yeah, absolutely. No, I remember that. Yeah, I think that patient had nasal involvement, which is a clue. Yeah, 100%. So I'll tell you all about Tuesday's case. I think it was really, really intriguing. The patient came in with ptosis and weakness, and was ultimately found to have on exam areflexia, mild weakness, and bilateral ptosis. And it was really tricky to localize. The interesting thing about ptosis is that there's very few CNS explanations for ptosis, because the lesion often is either a drop in the parasympathetic output or the sympathetic output. And most of that happens in the peripheral nervous system. And they layered on that the fact that the patient's acetylcholine antibody receptor was positive. So think about that. You're in a situation where you have somebody who has ptosis, a very compatible symptom with myasthenia gravis, probably one of the most common neurological causes. And then you get such powerful data to support it, which is that the patient has acetylcholine receptor antibody. That's the setup for multiple sclerosis, myasthenia gravis, excuse me. Confusing my neurological diagnoses. Can you all think of the tension in this case? Like, how is it set up to make it really hard to solve? So if I had to identify, like, what's the major roadblock of a patient with ptosis, a positive acetylcholine receptor antibody, weakness, that's mild, but areflexia? Thoughts?
I guess the areflexia is the part that is very tricky for me, because actually in myasthenia gravis, I wouldn't expect it. Like when I think of areflexia, for me, this is okay. I mean, because myasthenia gravis is a disease that affects the neuromuscular junction, but not the second motor neuron. And that's something that is very tricky to me. Like I would have expected areflexia and something like Guillain-Barré syndrome, or as a sign of a second motor neuron, but not in an MG.
100%, exactly right. And you're reminding us, if you're thinking of the neuromuscular junction, so the neuro and the muscle, the closer you are to the muscle, the more likely you are to behave like a muscle or myopathy. And so disorders of the neuromuscular junction, if they're on the muscle side, like myasthenia gravis, which you said is a postsynaptic, they look like muscle. So myasthenia gravis is a pure motor disease. Nothing else is affected except muscles. And so reflexes should be normal. Sensations should be normal. The interesting thing is this might mean that the mental status should be normal too, but there is a way that you can get pretty confused with myasthenia, and it happens. And it happens when you get some diaphragmatic involvement, that you get respiratory acidosis and you get confused. And that's unfortunately one of the early signs of decompensated crisis. One very morbid sign, honestly. It shouldn't be early, like we should catch it well before that happens. But yeah, so you're right. In this case, there's a tension, and that tension is this person has hyporeflexia, so it can't be myasthenia gravis alone. And so you're right, when the reflexes are dropped, it's either a nerve problem or a disorder at the nerve side of the neuromuscular junction. And the best example of that is botulinum toxin. It depletes the acetylcholine from this nerve. And the same is true of Lambert-Eaton. It affects the calcium channel on this side. So those patients are almost always hyporeflexive. So then you can analyze this case and say, hey, maybe this person has two neuromuscular junction disorders, both myasthenia and Lambert-Eaton. Is that a possibility? but it's not. And what happens is this patient is on immunotherapy. And what immunotherapy has done is it has caused two simultaneously different, but both immune-mediated diseases. There's an immune-mediated neuropathy from it and an immune-mediated myasthenia gravis from the same thing. So the common denominator is not some neuromuscular junction exposure. It's the fact that the patient has immunotherapy causing multiple antibodies to happen simultaneously. Yeah, which was a really, really ridiculously surprising explanation.
Just thinking about last week's neuro VMR. Remember, Shema, you were there? It was stiff person syndrome, but it had a signature of also myasthenia gravis that we were thinking about. But I guess at both there was anti-GAD and also findings of myasthenia gravis as well. But yeah, the fatigability element was missing. I didn't listen into this one, but that's missing. So that definitely confuses me.
Unfortunately, I wasn't there on the episode of the stiff person syndrome, but I was so sad when I heard it because I really saw one case of stiff person syndrome in a clinic, and I had a very it was a really cool impression to see this in real life because we had before we went to the patient, we had read that these patients are very easily anxious, or you can frighten them very fast. And what happened was some students of my course were okay, trying to make her frightened, and then she was so angry with us that almost she didn't want to get an examination from us, but to see we have to be very careful with these patients. And it was also the stiffness, especially proximal, was very visible there. So it was actually in the book she had diabetes type 1, and yeah.
Oh, absolutely, yeah. So with myasthenia proximal, stiff person proximal, Lambert-Eaton gets better throughout the day, whereas myasthenia gets worse throughout the day. So a complete difference between them.
I can also cite someone that I know from one of my Graz friends. He also presented one case of stiff person, and this was paraneoplastic. That was thymoma. And we were thinking, is it myasthenia gravis? But it came out to be stiff person. So because sometimes it can also be I think it was anti-empiphysin mediated stiff person syndrome.
Shema, there's nothing that could supersede what you just said in terms of its quality, except the fact that Kushal has joined us back on VMR, which is a delight to see. And I know he probably can't say hi or turn his video on, but Kushal, we missed you. It's so nice to see you, as Ravi is echoing in the chat. Yeah, beautiful reflections. I think it just goes to show you that you have to remain humble, and when things don't make sense, sometimes finding the proximal root, either a cancer or immunotherapy causing basically neurological chaos. You know, Deborah has 2 VMR styles about, both Sunday and Wednesday. So whichever one you want. But say hi first.
Hi, everyone. I'm excited for this new project on Saturday. This week, unfortunately, I didn't connect much because I was having exams, but on Sunday, we had a great VMR. Madellena was discussing, maybe she can remind me, but was a patient with 56-year-old male with dyspnea and cough, non-productive cough, and some night of sweats. And he had smoked for 30 years. And the first thing that was thought was infections. And I thought about TB, of course. And then the patient was getting really bad with tachycardia. He had the saturation of low, the pulmonary with reduced breath sounds, and the labs was not great at all. He had low platelets, low sodium. He was acidemic, acidemic. So in the end, we figure out that the patient has a fulminant legionellosis with DIC and IRDS. And I recently had studied Legionella, and I didn't know that can cause all of that. I got surprised because I had 1 week that I had read something about it. And then we discussed a lot about the infections causes that could cause like both like thrombocytopenia, transaminitis, hyponatremia, lung and renal injury. And I didn't know that we had a lot of infections that could cause that, like HIV, rickettsia, leptospirosis, hantavirus. And it was a really surprise for me. It was a great case. So I think everyone should take a look in the whiteboard in the website.
Go ahead. No, go ahead, please.
Oh, I was just going to comment on that. That case stands out to me because it started off as, dyspnea and cough for 2 weeks, and we kind of walked through a very systematic approach to that. And then as the case went on, the patient got sicker and sicker and sicker. And if you see on the whiteboard, you can see from the labs and imaging, there was just so much abnormal data. And for me, facilitating with Jack, which was so much fun, I found it really challenging to figure out which of all the abnormal data to focus on. And I mean, I guess kind of the takeaway was that there was just multiple organs were being affected by how severely ill this patient. But I found it really difficult to figure out what was signal and what was noise. So for example, the UA showed some protein in some blood. So we were initially thinking, should we go down the schema for glomerulonephritis? I think the bilirubin as well was really high. So I remember discussing it and finding so many abnormal data pieces and finding it difficult to navigate through that. So that was challenging. But actually, one question I had for the group that I didn't get a chance to look up is, in my illness script of Legionella, I know hyponatremia is commonly seen with that, I believe. And I'm not exactly sure why. I didn't have a chance to look into that. And I was wondering if anyone, is there an underlying pathophysiology there, or kind of why is hyponatremia commonly seen with Legionella? I don't know that.
I think
it was at SIADH.
I think it's because when you have Legionella, you have also GI symptoms like diarrhea, vomiting, and that it stimulates the release of AGH, leading to the hyponatremia. But correct me if I'm wrong, Rabbi, please.
And so I guess why would that be specific to Legionella? Yeah.
I'm so glad you're asking this question. It's actually it's crucial. And with it comes this idea that you have to be careful about things that are perpetuated as a common fact. And this is a great question because the answer is there's truth there, but it's nuanced. So how many infections can present with hyponatremia? The answer, unfortunately, is every single one of them, right? Can you think of an infection that can't lead to hyponatremia by the fact that the patient feels crummy, no longer eats well, no longer consumes enough dietary salt, get some AKI, and there you go, done, easy, right? So what is this magical association with Legionella and hyponatremia? Is it just fallacy and some sort of made up nonsense? And there's a lot of that stuff in medicine. And part of learning is knowing which things to unlearn. But this one actually is a nuanced truth. It's not a falsehood. And the nuanced truth is that the mechanism of hyponatremia and Legionella is through SIADH. So patients with Legionella, when they come in, they have a hypovolemic component, but their ADH is way higher than it needs to be. And so even when you correct the hypovolemic component of anyone who's been nauseous and vomiting, as Rafa just said, they remain hyponatremic. So they uniquely cause, they are relatively unique as an infection to cause SIADH. And the cool thing is the short list of things that disproportionately cause SIADH as an infection is you go from all of them causing any kind of hyponatremia to only 3 that cause SIADH. There's not that many. Yeah, and those 3 are zoster. Zoster notoriously causes hyponatremia, Legionella, and TB. So if you're going to use hyponatremia as a clue to figure out what's going on, you should make sure that it's not hypovolemic. You're wasting your time. But if it's SIADH, you can't commit to those 3, but you certainly prioritize them if there's already a lead to follow.
Interesting. I didn't know that. Wow. Yeah, I think throughout med school, as you said, you just there's these certain facts that stick in your mind and you're not really sure, why that is.
Totally.
And I guess another question I had is, reflecting back, what are some clues that should narrow you in on Legionella specifically?
Yeah. Another, like, I think the what you're showing here is the power of targeted questioning. You're looking at a case, and I think the two questions that you're asking right now are just like cut to the heart of it, right? And I think that's another skill set that we are passively cultivating in VMR, is how you actually pick up on a clue, how you actually like figure out what are the fundamental features of the case. So the SIADH is one, and you found the other one. Why does Legionella fool you, and how can you make it look more familiar? And I think the answer into these questions comes from stealing from your knowledge base that you have already developed. You could start to learn new things about Legionella, or you could just simplify it and say, like, it is, I know this thing, so I'm going to use this thing and add a few things to make it look like Legionella. And the reason that we get fooled by Legionella is because it behaves differently. When you're thinking of somebody who has a pulmonary as a primary pneumonia, they don't usually have the hepatic and renal signatures that Legionella does. It doesn't usually cause a hepatitis and an interstitial nephritis. So in Legionella, they have an AKI because they get AIN. And so when you get regular old pneumonia, like strep pneumo, varicella, so on and so forth, we don't get that kind of injury. And more importantly, and a more powerful clue, is that the X-ray is bilateral GGOs, a very unusual pattern for bacterial pneumonia. So if you're thinking it's bacterial pneumonia, you're like, well, I could make it if I have to, but it's a stretch. And so that's one dimension. But the other dimension is, think about it this way. You have a patient with Legionella and they have anemia, thrombocytopenia, LFT abnormalities. They look all in the world like a tick-borne infection. And the other familiar part of them being a tick-borne infection is how high the fever is. They usually have a really high fever. I had a patient who had a fever of 104 from Legionella in real life. So the pattern is this pneumonia type thing that also has tick-borne infection-like features. And the reason that becomes helpful is because there's virtually no tick-borne infection that affects the lungs. They're very unusual. You can get ARDS from some of them. And tularemia is the only reliable one that does it. So the pattern of Legionella is very much like, oh, this person has a tick-borne infection. It looks like a rickettsia or anaplasma. There's a high fever. There's thrombocytopenia. There's LFT abnormalities. That combo is the defining feature of a tick-borne illness. But yet you see bilateral involvement in the lungs. And you're like, wait, what? That doesn't really happen much with tick-borne infections. And I think that's a big tip-off of Legionella. And in real life, though, the tip-off is the patient isn't getting better despite you giving them pneumonia antibiotics. And I think that that had it. I actually missed a case of Legionella for 2 weeks until a patient developed HLH from said Legionella on our watch. So it's very, very easy to miss. Yeah.
Oh, that was really helpful. Thank you. I did not know that. Yeah. Thank you.
Yeah, Legionella will fool you. I'm sorry. We'll try our best not to be fooled by Legionella, but it like designed to beat your cognitive skill set, because it's a really sneaky one.
Yeah.
What about the confusion that sometimes we listen?
Oh, such a good point. Yeah. All those infections like Legionella and the ones we tend to group with it, mycoplasma and chlamydia pneumoniae, they all do this thing where they can affect your cognition and your brain. Neurologists hate mycoplasma. It causes all sorts of post-infectious things. And of course, Shema's nodding vigorously, neuropassionate. There's neurophobia, and then there's the neuropassionate, which I think many of them in this crowd. Yeah. So they all do it. So Rafa, that's a very powerful clue. Yeah, she loved mycoplasma. Shocking. Also, that may be the nerdiest thing anyone has said so far, and that's an achievement. Trust me. Yeah, that's right. Oh, Kushal is making the great point that it's Oh yeah, see, you can do it's basically like the chat is developing an illness script for mycoplasma now. Hyperammonemia, pneumonia, and rash. Yeah, we do. JP, what's your favorite?
Strep anginosus.
Really? How come?
Abscess forming strep. It's the
Yeah.
staph-like strep. I love staph, but I also like I also like things that are a little bit out of the ordinary. So it's like the out of the ordinary staph presentation.
That's incredible. I'm gonna take a bet on Kushal's favorite that it's melioidosis, but I may be horribly wrong. I'm gonna leap in there. Yeah, Melanie, to answer your question, I don't think so. Yeah, it's like a completely different kind of organism. Woo, we nailed it. All right, you want to tell us about Thursday?
Yes, Thursday. Okay, let me pull up the whiteboard. Let's see. Sorry, I had the other whiteboard up.
No, that's cool.
Oh, the febrile headache. Oh, this is a great case. Okay.
Yes.
So this is loading. Oh my gosh, load. Oh, febrile headache, perfect. Okay, so this was the case that Ravi and Shema co-discussed, and Shema just did an absolutely incredible job. There were so many amazing teaching points, and also just the way you approached it, and kind of were very humble about your gaps in knowledge. So it was just a fantastic case. So I'll just summarize it briefly. So the chief concern was a febrile headache, and this was in a 28-year-old man with this kind of subacute history of fever, headache, and then kind of nausea and malaise. And there were some important, there was important past medical history that came up. So the person had an HIV infection that was well controlled on ART. Oh my gosh, I'm sorry, the whiteboard just disappeared.
Okay, take your time.
Let's see. Oh, whiteboard's not loading. Okay, here we go. So he had a previous HIV infection, but it was well controlled on antiretroviral therapy. And importantly, we had information about the CD4 count, which was 600. Which kind of further clued us in that this was not a severely immunocompromised host. And then importantly, in the labs, we found that they were afebrile. There was some tenderness in the right upper quadrant and hepatomegaly. And then really kind of what was the crux of the case is that there was severe transaminitis. So the AST and the ALT were in the 5,000s and 4,000s. So I think some of the two big things that I took away from this case were when you have a febrile headache, kind of important things in the history that you want to ask about, which will make you go down two different paths. So I kind of actually wanted to turn it over to the chat here, to the audience here. So with a person with a febrile headache, like what are the first things coming to your mind and what questions would you ask? Because that was really something that I took away. Okay, so Soldan's mentioned IMAID in the chat. Soldan, can you unmute and kind of share where you're thinking there is coming from, if you're able to unmute? Well, yeah. Let's see.
My head.
Oh no, the connection is not great. Do you want to try again, or maybe do you want to try again, Soldan?
Okay, what about now?
Yes, awesome. Tell us what you were thinking.
Thank you. I think this is the first time I'm in the CBS VMR meeting, and I'm very delighted to be in this Zoom meeting. I'm
so happy you're here.
From East African country called Somalia.
Welcome.
I think when we feel any fever, the way we can think about is this schema that I also saw from the CB Surface website, which also involves the time. So it's the infections in the earlier time, and then after some time we can think about malignancy or autoimmune diseases, and then also drugs are possible cause, and also endocrine causes. There are endocrine causes like thyroid or other endocrine conditions. Like that is what I was thinking about when I said IMED. Thank you.
Yes, that's so beautifully said. And I love how you gave examples from each of the categories. That's really spot on. And I actually think Shema mentioned the IMED mnemonic in her discussion because, you know, fever, as we know, is a really, you should kind of translate fever in your mind to inflammation, and then you can use that mnemonic that you just really beautifully shared. I'm curious, Soldan, if you or anyone else has thoughts when you add on fever, when you add on headache to fever, does that change how you're thinking about your initial differential? Oh, Max, you shared some really great thoughts. What do you think?
Hello. My first idea was that general virus syndromes like EBV, CMV, SARS-CoV-2, and secondly, you have to thought about the morbid diagnosis of meningitis. And then I would do an exam test for meningismus and see if the patient has photophobia and warning signs like vomiting and stuff.
Yes, exactly, exactly. And Amir also shared really related thoughts. Amir, do you want to unmute and kind of add to what Max said?
Well, I guess for me, I started the other way around, and it was a nice case to learn not to anchor too much on meningitis, because I think for me it was always like fever and a headache, let's jump to meningitis. But yeah, base rate is probably also very important, as to realize that you know, it's most commonly going to be caused by just common virus. So I think that for me is from maybe lack of very practical experience. So I just jumped to the, but still I think it's also important to rule out life-threatening causes first.
Yeah, I am 100% with you. I think when I hear fever and headache, my mind also jumps to, you know, meningitis and some of these more do not miss causes. So it was also a big learning point for me to remember the base rate and prioritize those, and remember that kind of a systemic viral infection is what's more common. But as you and Max beautifully shared, you know, asking questions like neck stiffness, photophobia should really make you consider getting an LP and be more aggressive about some like meningitis and more morbid causes. So that was one really important takeaway for me. The other important takeaway, there are a lot of them, but I want to make sure we have time to discuss. I think the last thing is kind of the severe elevation in the transaminases. So as I said, they're in like the 5,000 and 4,000 range, which is really high. And I wanted to also ask the chat, when you see that level of transaminitis, I know eventually we'll talk about it did lead to an infection, but even before we put it in the infection category, what things can cause an AST and ALT in the thousands? Yeah, Rafa, you want to unmute and share what you think?
Sure. I usually think about things like infections such as hepatitis A, the most common virus. Also, shock liver could lead to that, and autoimmune hepatitis. I think that's a good thing to remember, because that we could differentiate for example, alcoholic hepatitis, which usually don't lead to up to 1,000.
Oh, interesting. Yeah, that's kind of what I have in my mind, like shock. So ischemia, my understanding is, can lead to AST and AST and ALT so high, like viral hepatitis we talked about. I actually didn't know about autoimmune hepatitis, so that's really interesting. And then Kushal also mentioned some great bugs. Kushal, do you want to unmute and share your knowledge about what infections can cause AST and ALT that high? If you can unmute.
Sure. It's been a long time since I attended VMR. It's nice to see everyone.
Welcome back.
Thank you. So yeah, the infections that come on top of my head, besides what Rafa mentioned, is CMV, HSV, possibly adenovirus. And there are other infections as well that can cause cholestatic pattern. But I'm not aware of anyone that can cause AST/ALT in thousands. But Rafa can possibly add to.
Yeah, no, that's beautiful. I actually think you know, and Robbie can put it in his own words, but he shared some pearls in a way that really stuck with me. So you have like these professional infections that kind of target the liver, so the hep A, B, C, D, E, and then you have these, I think Robbie, you called them like casual infections, and so those are like dengue and yellow fever, and then the herpes viruses, Kushal, like you mentioned. So that was also a big takeaway for me. But yeah, I really like Rafa and what other people shared in the chat, like thinking of ischemia, like shock liver, and then even autoimmune causes, which I didn't know about. So those are my takeaways from Thursday's case. Yeah,
that was amazing. Thank you for that recap. It was, and I think you highlighted the two key salient features of this case, and I think the first is to make sure that you know exactly what you're dealing with when you have liver injury that high. And the truth is, there's a little bit of a nuance to that case that allows you to make more progress than the broader DDX of acute liver injury that bad, which is to be mindful of whether you're calling it liver injury or liver failure. I think we're taught that that is purely a management distinction, but it actually profoundly influences the causes. And here's the way to remember it. So what if I tell you first that your patient has AKI, full stop? And then I tell you that patient number 2, another patient, has AKI requiring dialysis. What do you think happened to the diagnostic possibilities when the second patient now requires dialysis? This is to anybody. What happened to the diagnostic landscape? Just diagnosis alone.
I mean, this is just a thought. So if you have AKI and then AKI requiring dialysis, it's like, if it's requiring dialysis, to me, that means the kidney is not able to function and you need to intervene because there's some sort of failure. So maybe the injury is like irreversible, maybe, versus AKI, perhaps the damage is like reversible and you don't, it hasn't completely failed. I'm not sure about that though.
That's exactly right. So sometimes getting to the bottom of something may mean that you just don't know this thing, or that you have to ask yourself a different kind of question to access that knowledge. So I'll rephrase that question. What do you think the chances of somebody having pre-renal AKI requiring dialysis? Right? Like, yeah. Oh, you said it. 0. Right? At that point, there's definitely intrarenal AKI. It's impossible, right? What's the most common cause of AKI not requiring dialysis? Pre-renal AKI. So as soon as there's organ failure, the probability of something with the plumbing, pre-renal, and the other kind of plumbing, post-renal, is very, very, very low. There are so many more profound warning symptoms like shock and confusion and severe pain from urinary retention. Like, those things warn patients well before they've gotten dialysis. They can't tolerate that kind of discomfort. And the same is true for the liver. So as soon as somebody has acute liver failure, the plumbing issues like ischemic hepatitis and biliary issues become almost 0. But those two are the most common causes of acute liver injury. So if you really take the extra step to label that patient as having encephalopathy and a coagulopathy, and you change the calculus from acute liver injury to acute liver failure, infections and toxins become super high. So the case to just immediately drop all your diagnostic weight on an infection is both for the morbidity of the patient. But if you look at the case with that lens, it's also just the wisest investment of your cognitive energy. Because otherwise you'd have to think, could this person have ischemic hepatitis or biliary stones? But you don't have to even think about that in that case. Yeah. So I think that was that recognizing that, emphasizing that is key. And then of course the like home run discussion. Oh my God. She's too humble, so I won't say her name again, Shema. Oh, sorry, I said it. It's just unreal. It's really, really cool to see. Rafa, you want to round it out? We're almost done.
Sure. So I'm going to be talking a little bit about the case on Friday that we had. So this was a 68-year-old male. He presented with back pain for 2 weeks. This back pain was initially attributed for the fact that this patient has been hospitalized for 2 weeks before due to severe hypokalemia. So the journey was, do I worry about this back pain or not? So Reza spent a little bit of time talking about when we should worry about back pain. And I think it's super important because, if I'm not mistaken, back pain is like the second most common cause why patients go to the hospital. So you have to worry about back pain if you're dealing with red flags. So it's really important to know them and sort them out. Things like if there's any cancer history or if there are any constitutional symptoms like fever or weight loss, if there is like night pain interfering with the sleep of the patient, or if the pain is irresponsible for previous therapy, and also the fact that if it's like chronic pain or even chronic back pain in a young patient, those are like red flags that should be careful about. If there are no red flags, Reza reminded that it's probably things like muscle strain. So NSAIDs are usually fine for the patient. And another thing that I read that I found interesting is that in those cases, even in those cases, we should not recommend that this patient stay in the bed for a long time. You should actually recommend moderate and regular activity because that will decrease the duration of the back pain. If there is back pain, this is something I learned with UWorld. You can actually check ESR. If it's elevated, you should be concerned about that because this is associated with inflammation or even malignancy. Inflammatory conditions, things like osteomyelitis and epidural abscess, all those can increase the ESR. And another thing that we should be very careful is neurological deficits. For example, bowel and bladder dysfunction, fetal anesthesia. If you see those things in a patient, you should require an MRI, urgent MRI, to exclude things like cauda due to the infection or tumor. And this is particularly interesting for me because I remember I took a question wrong because I wanted to give like glucocorticoids for the patient, but the patient had a history of IV drug use. So I should be worried about epidural abscess and not a tumor leading to the cauda. And we usually don't have to give like glucocorticoids for patients who are having infection because you could actually make the thing worse, like you're blunting his immune system. Another pearl that I loved because it was like malignancy that could affect the bones. There's this mnemonic that we usually learn in med school that is like the lead kettle, PB kettle. So for PB, prostate and breast, but also kidney, thyroid, and lung. All of those could go to the bone and lead to malignancy. That were my main takeaway when it comes to the back pain. And finally, another takeaway that I think it's really important is the hypokalemia that this patient presented with. So I learned from UWorld that there are like 1, 2, 3, 4 or 5 buckets that could lead to hypokalemia. One of them we already discussed today, which is the decreased intake. For example, patients with anorexia could be having hypokalemia. Or intracellular translocation, for example, patients with DKA and you give insulin to them, that will lead to hypokalemia because the insulin will make the potassium go inside of the cells, but also beta-adrenergics, things we do for patients, like if you give them like a lot of albuterol, you could actually lead to hypokalemia. Any respiratory or metabolic alkalosis could also lead to that. GI losses are very important to remember, like diarrhea, vomiting, urinary losses, like hyperaldosteronism or RTA types 1 and 2. And finally, sweat loss. I think it's less common. If you see a patient running in the desert, you could think about hypokalemia as well. So those are my biggest takeaways.
I love how your biggest takeaway took us to a desert, which is the ultimate irony because your takeaways were so superb and rich. That was awesome. Thank you. I don't have anything to add to that case. I think you hit all the really key and important points. So maybe we can spend a couple of minutes just to open it up to everybody. Anybody have questions or things they want to reflect on before I bid you adieu? That was marvelous.
I actually had a question about this case. So I was, well, also in the chat, if you guys missed it, Shema just walked through this, the mechanism of kind of why hypokalemia is present in Cushing. So Shema, you should totally share that. You should totally share that just for the group, because I was also confused and had done some reading about that. Yeah, but yeah, go ahead.
Okay, sure. So I remember this from one lecture that I had in my, I guess, first or second year, and it was mentioned if you have too much cortisol or glucocorticoids, they also bind to the same receptor as the mineralocorticoids do, like aldosterone. So basically, if you have too much cortisol, they lead to the effect of the ENaC, as we know. It leads to the intake of sodium and to the excretion of potassium. And usually in physiological states, the mineralocorticoid effects of cortisol is being inhibited because there are these enzymes like 11-beta hydroxysteroid dehydrogenase. We have two types of them, and they lead to the inactivation of cortisol into cortisone, the inactive form. But if you have too much cortisol, I think that this mechanism doesn't work. And then this was also something that Mukund asked me yesterday, and then we were talking about licorice, like basically how this is leading to pseudo hyperaldosteronism, because these licorice they inhibit the inactivation of cortisol into cortisone. Yeah.
Oh, I can't believe this is one lecture that you took away, like this permanent takeaway from. And I think it actually it's the line of thinking to one of the most interesting questions I've ever thought of, which is, can you think of a cancer that secretes something that helps it grow? And here's the premise. The premise is that cancers usually secrete things that cause paraneoplastic problems, right? But the really interesting thing about adrenal cancer is 25% of them secretes ACTH. Now, what do you think of a cancer like an adrenal cancer secreting ACTH? What do you think it does to the cancer? Yeah, Amar, tell us more. Nailed it.
I have nothing more to offer.
No, but
I
how did you
just
come to that thought? No. How did you come to that thought? Don't come at me with that humility. You know, how did you get there?
Well, so normally, if we have secretion of adrenocorticotropic hormone, it's in the name. It's corticotropic. It causes growth of the cortex of the adrenals. So if you're secreting something that causes you to literally grow, I guess you'll grow. That's all the circular logic I have for today.
Oh, it's superb. It's absolutely correct. I think you went from I have no idea to, oh, it's in the name. And it goes to show you how much you know. Yeah, I think what tends to happen is you secrete something that literally is making the adrenal gland, the whole adrenal gland trophic, but disproportionately the tumor, because you also suppress your immune system. So everybody who has Cushing's, the rate of malignancy in patients with long-standing Cushing's is high. And that's because you suppress the immune system, no different than the rate of cancer with anyone who's immunosuppressed is higher. HIV, much higher. Solid organ transplant patients who are on immunosuppression, like everyone who is immunosuppressed has a higher risk of malignancies that includes Cushing's. So when somebody's coming in with Cushing's and you're evaluating them for the first time, there are some things that you should think about as acute complications, and one of them is infection, as Madellena and Shema emphasized, but another is cancer too. And by the way, another big one is PE. So getting that patient got a CT scan, which is a great idea because Cushing's patients are also hypercoagulable. Yo, I really enjoyed hanging out and reflecting with you all. I hope you had a good time as well. Yeah, we'll try to do this more often and more frequently. And I will open up the mic for for our parting words to see if anyone has anything to say. Otherwise, we will bid you adieu and see you for student VMR with this dream team tomorrow. All right, catch y'all later. Bye.